Sir, start करें sir.
Good evening, ladies and gentlemen. Welcome you all to this webinar on ECG Basic and Beyond. This is the 13th day of this webinar series. We'll talk on ECG in electrolyte and metabolic disorders and many other factors also. We have got two course directors with us, Professor M. Atahar Ali from Evercare Hospital and Professor Abdul Wadud Chowdhury from Dhaka Medical College Hospital. And we also have got our international advisor, Dr. Rafiq Ahmed sir with us. We have got two foreign faculties with us, Professor Arun Maski and Professor Hafizul Hassan. Our session will have three parts, mainly four parts mainly. The first session will be delivered, first lecture will be delivered by Dr. Khalequzzaman, second one by Professor Arun Maski, third one Professor Chowdhury Hafizul Hassan, and the fourth one will be the ECG of the week. And if we can, time permits, Dr. Rafiq Ahmed sir will show us some ECG. So with the permission of the chairpersons, Atahar Ali sir, do you want to say something about today's topics? Atahar Ali sir, please.
We are happy that Professor Abdul Chowdhury just joined with us, and this is an announcement that Dr. Rafiq Ahmed sir has called me that he will join shortly, that is in 5 to 10 minutes, that is Rafiq Ahmed sir is coming, and we have got some good number of the respectable faculties like the Professor Mahbubur Rahman, Arun Maski, Abdul Al Jamil, Professor Mohsin Hussain, and I am happy to announce Chowdhury Hafizul Hassan is also with us, and Rafiq sir is coming. So, Professor Abdul Wadud Chowdhury, yes, it is your part to introduce our Khalequzzaman. We are waiting for his lecture. Professor Abdul Wadud Chowdhury.
Dr. Khalequzzaman, who is my colleague in Dhaka Medical College, has always been a very quiet, unassuming, but an in-depth scholar, I would say. He always liked to go in the deep of things, find out what is what. And you will find that out in his lecture. Without describing much, I do hope you'll be finding out many more things, something that we know, many things that we do not know from his today's lecture. I hope you will all enjoy it. Dr. Khaleq, please.
Thank you, sir.
Thank you, sir, for a nice introduction.
Dr. Khalequzzaman, I think all of you know him. He's working as a professor of cardiology, Dhaka Medical College. He was a graduate from Dhaka Medical College and later on had his FCPS in medicine and MD in cardiology. And he's a very good teacher, brilliant physician, and is idol for many of our junior colleagues. And Dr. Khalequzzaman has already delivered his lecture on ECG in electrolyte and metabolic disorders in the first part 2 weeks back, and he will continue with the rest of his lecture today. May I request Dr. Khalequzzaman to deliver his lecture? Dr. Khalequzzaman, please.
Respected course directors, Professor Atahar Ali and Professor Abdul Wadud Chowdhury, Dr. Hafizul Hassan sir and Dr. Rafiq Ahmed sir from USA, and my senior and junior colleagues and cardiologists and the students. Assalamu alaikum and very good night. Let us start our presentation. Before going into the presentation, I want to express my great thanks and gratitude to Professor Wadud Chowdhury and Dr. Firoz for a nice introduction for me, which is not I am fit for. Now, slide sharing. Can you see the slides?
Yes, we can see your slides.
Okay. Go back. In the previous day, we were discussing about the electrolyte disorders and partly metabolic disorders. Now, rest of the part I have labeled is as extracardiac disorders that changing the ECG pattern. And how can we diagnose the extracardiac disorder with the ECG changes, or how the ECG changes in extracardiac disorder can confuse with certain acute cardiovascular events during its occurrence. So we will be discussing on ECG and respiratory disorders, ECG and hepatobiliary disorders, because among the all gastrointestinal disorders, the acute ECG changes are more confusing with the acute coronary syndrome with some hepatobiliary disorders. ECG in stroke, again, acute stroke may confuse with several patterns of acute coronary syndrome. ECG in thermal disorders, and I could not stop my interest to express some ECG change during the pregnancy, although it is not a disorder, rather it is a physiological, altered physiological state of a female. But it is very significant, I think, in our practice in Dhaka Medical College, where is a very tertiary level hospital, we have to frequently encounter the cases of pregnancy where there is some certain abnormal ECG change, either due to organic cause or due to itself, the pregnancy induces certain electrocardiographic changes physiologically. So you have to know all the things, you have to discuss all the things. In ECG in respiratory disorders, COPD or a chronic obstructive pulmonary disease, one of the commonest form of pulmonary disease that we have to face in our day-to-day life, both the cardiologist, medicine specialist, as well as the pulmonologist always. How the ECG is changing during how the ECG is changing in chronic pulmonary obstructive disease. If we see the pathogenesis or the physiological change occurring in disease status, like presence of a hyper-expanded emphysemeter lungs within the chest, that may produce an insulating effect of the electrical transmission from heart to the surface of the heart, surface of the chest. And you all know the long-term effects of the hypoxia is pulmonary vasoconstriction, which ultimately leads to pulmonary hypertension and right ventricular and right atrial loads. The expanding lung also pushing the diaphragm down, which also makes some changes in the orientation of the heart or position of the heart that may induce some changes in the electrocardiographic manifestation. So what are those changes? You know, all the P pulmonally or right atrial enlargement or strain. This P pulmonally, when we tell it usually when it goes above, height goes above the 2.5 millimeter, it is caused by right atrial strain. And there is shifting of the transitional leads more towards the left. We call it clockwise rotation of the heart. And there is right ventricular enlargement or hypertrophy, heart rather shifting towards the left, rather it rotates in a clockwise pattern, that may produce shifting of the transitional leads towards the left. And there is right axis deviation at a time, and RVS in the ECG, which is again due to right ventricular hypertrophy, which in majority of the cases mild to moderate, but at a stage when there is disease become far advanced, it become change into severe type of right ventricular hypertrophy. The low voltage ECG, one of the differential diagnosis of the low voltage ECG is emphysema, and this is produced by the lungs, which is encroaching over the heart, producing a barrier or electrical transmission. There may be atrial arrhythmias, and the MAT is considered to be pathognomonic of the COPD changes, and it indicates decompensation. It is usually produced due to intermittent hypoxia and pulmonary vasoconstriction. We all know there is 4 ROA progression in the chest lead, which is considered to be due to depressed diaphragm, and ultimately due to severe right ventricular hypertrophy, patient may once a time develop right bundle branch flow. It is called a Qrs ECG criteria for diagnosing the COPD. Here there are changes involving the atrium and involving the ventricular depolarization and the repolarization. What is change in the atria? Atria, if there is presence of P pulmonally, it is one of the criteria. If the P of axis is more than 80, usually P of axis ranges from 0 to 80 degree or 85 degree. When atrial, these are two mainly manifested, considered as a criteria for Qs diagnosis, ECG diagnosis of the COPD. The QRS changes are QRS amplitude less than 5 millimeter in all limb leads, or QRS axis more than 90 degree, or QRS amplitude less than 5 millimeter in V5, V6, or certain pattern, if there is any certain pattern like presence of RS ratio more than 1 in lead 1, 2, and 3. It is called S1, S2, and S3 pattern. And again, presence of atrial arrhythmia is also considered one criteria for diagnosis of COPD. COPD is likely to be present if one POF criteria and one QRS criteria is present. So let us see some ECG. You see there is rate is increased, sinus tachycardia. You are observing that the patient has got low amplitudes, QRS complexes, which is more prominent in the one laterally, anterolaterally, it's one ABL, V5, V6. And there is large or tall POF in the limb leads, particularly lead 2, 3, and AVF. And there is axis deviation towards the right, and there is non-progression of the R wave, and there is almost absence of R wave in the right precordial lead. It's called as V1, V2, and V3 pattern. You see the next ECG almost similar. The rate is increased, P height is increased, and you see the low voltage in the anterolateral leads, and also there is shift of the transitional leads towards the left as far as lead V6, and there is rightward axis deviation. So all these changes is possible in COPD. And in this ECG, you see the multiple POF morphology in the same lead. In lead 2, you can see the rhythm strip, that the multiple POF morphologies in the same lead we are calling is multifocal atrial tachycardia, or when the rate is less than 100, multifocal atrial rhythm. Here other ECG changes are also here. Now we'll shift to ECG in pulmonary embolism. Why there is changes in pulmonary embolism? Although the pathology or the disease in the lungs, but the manifestations in the ECG are rather very much pronounced in certain times and may confuse with the acute coronary syndrome. So why there are ECG changes? Due to dilatation of the right atrium and the right ventricle with consequent shift in the position of the heart, right ventricular ischemia when there is right ventricle is struggling against a high pressure overload, then there may be right ventricular ischemia. And at the same time, due to pain, anxiety, and hypoxemia, there may be increased sympathetic discharge leading to increase in the heart rate, which may further aggravate the relative ischemia. So what are the ECG changes and what is the pathophysiology? Sinus tachycardia, although there are several changes, but the sinus tachycardia is considered to be the most common abnormalities in cases of acute pulmonary embolism, which is occurring due to sympathetic stimulation or sympathetic discharge. P pulmonally, you see there is an acute right atrial and right ventricular strain that ultimately lead to right atrial dilatation. S1 Q3 T3 pattern, it is occurring only in 10 to 20% of the cases, although it is very classic or most popular change, and everybody wants to memorize it, but the occurrence is only 10 to 20%. Right bundle branch block, either complete or incomplete. When there is complete, it indicates worse prognosis. It again due to production of the acute pulmonary hypertension, due to severe vasospastic component of the pulmonary circulation, secondary to occlusion of the main pulmonary artery and hypoxemia. Then acute rightward axis shifting due to clockwise rotation of the heart, and more or less specific one is T inversion is V1 to V3. It occurs almost 40 to 50% of the cases, and it is occurring due to increased RV wall stress leading to right ventricular ischemia. And lastly, the atrial arrhythmias in the form of tachyarrhythmia, particularly atrial fibrillation or atrial flutter, which occurs in only 8% of the cases, and majority are due to RV dysfunction or presence of the atrial dysarrhythmias indicates the patient is going to develop RV dysfunction. Here there is one criteria called Daniel ECG criteria for diagnosis of the severity of the pulmonary embolism. Here there are 21 points and scoring system, 21 numbering score. There are 7 criteria. Number 1 is due to sinus tachycardia. They will get 2 points. When the patient shows incomplete right bundle branch block, they will get 2. And you see, against all the points, including the Q wave in lead 3, inverted T lead 3, and the S1 Q3 T3 pattern, will get 2. And total score is 21 points, and interpretation is like that. When the score is more than 5, it is consistent with the pulmonary embolism diagnosis. But when the score exceeds more than 10, it is consistent with severe or massive pulmonary embolism. So what is a lot of changes in cases of acute pulmonary embolism, but what is the most common change? Most common changes are sinus tachycardia, which occurs in 40 to 50% of the cases, and the T wave inversion in the right precordial leads from V1 to V4, 30 to 35% of the cases. So this is the most consistent association of the pulmonary embolism. What is the most specific ECG change? There is simultaneous T wave inversion in the inferior and the right precordial leads, which is the most specific change. It indicates right ventricular strain. And reported specificity is up to 99% in one study. So specific change is T wave inversion in the right precordial leads with or without change in the inferior leads. What is the classic or popular findings? Again, it is S1, Q3, and T3 pattern. That is deep S wave in lead 1, Q in lead 3, and inverted T wave in the lead 3. So this is called S1, Q3, and T3 pattern. We'll later on touch on this topics later on. And what are the ECG changes that indicates poor prognosis in a patient with acute pulmonary embolism? These are complete right bundle branch block, incomplete, although a bit worse, but complete RBB, when there is presence of complete RBB, it indicates worse prognosis. If there is any ST elevation in the right precordial leads in V1, V2, and V3, sometimes mimicking the acute myocardial infarction, that is due to severe right ventricular strain. So it indicates again a poor prognosis. When there is low voltage Qrs complexes in acute pulmonary embolism, it is a sign of worse prognosis. And presence of atrial tachyarrhythmias in whatever the forms, again it indicates a poor prognostic ECG sign. Clinically, definitely, when the patient present with chest pain, hypotension, shock, and along with other autonomic manifestation and respiratory distress, there is strong doubt, and the strong differential diagnosis is acute coronary syndrome. It has been shown that simultaneous T wave inversion in lead 3 and V1 are diagnostically significant. Negative T waves in the lead 3 and V1 were observed in only 1% of the cases with acute coronary syndrome, as compared with 88% of the patients with acute pulmonary embolism. So simultaneous T inversion in lead 3 and V1 is very significant to differentiate between the acute coronary syndrome from the acute pulmonary embolism. You see the sensitivity is 88%, specificity is 99%, and the positive predictive value is 97%, whereas negative predictive value is 95% of the ECG change in lead 3 and V1 for diagnosis of pulmonary embolism. In conclusion, it can be said that the negative T waves in both leads 3 and V1 allows pulmonary embolism to be differentiated simply but accurately from the acute coronary syndrome in patient with negative T waves in precordial leads. So we'll see the few ECG that are occurring in pulmonary embolism. You see in this ECG that there is tachycardia, sinus tachycardia, rhythm seems to be sinus, and on the right sided precordial leads you see there is right bundle branch block pattern of ECG changes, and the T wave are inverted in the right precordial leads. And here you are seeing the patient has got classical right bundle branch block with a bit wider configuration, and there is right axis deviation, and at the same time T wave inversion in the right precordial leads, and more classical findings are leads S1, Q3 and T3 pattern. This is another ECG which shows the precordial leads. There is T inversion. Patient has got sinus tachycardia around 100, and the inferior leads as well as the anteroseptal leads also shows the T inversion. This ECG is also showing the sinus tachycardia and other common changes. And this ECG you are seeing that there is evidence of the right ventricular strain and right ventricular hypertrophy. In V1, you are seeing the changes. Right axis deviation is there, and the T wave inversion in the precordial leads, and there is persistent NC the V5, V6, indicating the clockwise rotation of the heart. This is again an ECG where there are changes like the red and the ventricular ectopics, right bundle branch block pattern, simultaneous T inversion the precordial as well as inferior leads. Here we are seeing the complexes are more broader one. We have told that these are prognostic right bundle branch block. When it is complete, it indicates poor prognosis. And here there is broad QRS complex right bundle branch block pattern. Persistent S wave on the 6th, that is indicating clockwise rotation of the heart and the right axis deviation. The S1Q3 T3 pattern, which we are observing that the deep S wave in the lead 1 and the Q wave in the lead 3 and the Q wave inversion in the lead 3. This is termed as McGinn-White sign. It indicates acute right heart strain, whatever the cause. This is very classic, but on the other hand, it is a popular findings in the pulmonary embolism, but it is neither sensitive nor specific for pulmonary embolism. যতটা না আমাদের মনে রাখার কথা তার থেকেও বেশি আমরা এই জিনিসটাকে মনে রাখি. Yet then it is very classical findings found only in 20% of the patient with pulmonary embolism. So any cause of acute core pulmonary can result in S1Q3 T3 pattern. So if the patient has got sudden pneumothorax, either right or left, if the patient has pneumonectomy, or the patient has a posterior fascicular block, that may mimic the ECG of this S1Q3 pattern, which we are labeling or considering very strong favoring point in diagnosis of acute pulmonary embolism, but it's not like that. It is less specific. And now we'll be talking on pneumonectomy. Pneumonectomy means removal or surgical removal of the lungs in one side. It may be either a segmental pneumonectomy or lobar pneumonectomy or a hemi-pneumonectomy. So knowing the type of the surgical procedure and the extent of the pulmonary resection, which is very much vital for diagnosis of the ECG changes. If a single segment or a small lobe is resected, there may not be any change on the ECG. So the understanding and the recognition of the ECG changes after lung resection are essential to avoid confusion with other acute cardiopulmonary events. You see how the pneumonectomy can induce ECG changes. As there is no lung in one side, so there will be shifting of the position of the structure in the mediastinum and the chest cavity. So there will be some changes in the ECG. The reduction in the pulmonary vascular bed, if there is absence of half of the lung, so there will be reduction almost 50% of the total vascular bed. So it will produce some strain on the right ventricle. So there will be increase in the right ventricular afterload. And in acute and subacute cases, depending on the type of the surgical procedure, there may be injury to the pericardium, which may lead to change in the ECG pattern, either in the form of ST segment depression or elevation. And you see, in right-sided pneumonectomy, there is only lateral shift on the right side of the heart, and on left-sided pneumonectomy, there will be rotation of the heart in a clockwise fashion. The development of new onset right bundle branch block and new ST segment and T-wave abnormalities in the lead V1 to V2, irrespective of the site of the removal of the lung. These changes are common in both the sites. You see the ECG, the pre-operative ECG, there is almost normal ECG here, V1, V2, V3, and after post-operative period, the ECG changes are leading to right bundle branch block, just incomplete right bundle branch block. In addition to that, on the left-sided pneumonictomy, there may be left axis deviation. Somewhere there may be atrial dysarrhythmias, particularly in atrial fibrillation, which is very much common after any lung surgery, particularly pneumonictomy. So in the form of atrial fibrillation. Here you are seeing the ECG who has got atrial fibrillation with the first ventricular rate. At the same time, you are seeing that the ST elevation in the chest lead, beginning from V1 to V6 even, there are ST elevation. These are probably due to pericardial involvement during surgical procedure. What are the changes in pneumothorax is also common. We are servicing in multi tertiary level hospital where there is respiratory medicine department, where there is respiratory surgery department. So we have to frequently encounter these sorts of ECG changes. The ECG changes in pneumothorax depends on the size, site, and type of the pneumothorax, either it is spontaneous pneumothorax or a tension pneumothorax. Pneumothorax may mimic acute myocardial infarction both clinically and electrocardiographically, but important thing is that the treatment differs substantially between the two. So the recognition of the pathology is very important. So how they are changing the ECG? Because of rotation of the heart, because of right ventricular dilatation due to increased PA pressure, and cardiac displacement, depending on the site of the involvement, and air in the thoracic cavity, which acts as an insulation to prevent the transmission of the electrical impulses from the myocardium to the surface of the ECG where it is picked up. So all this pathology lead to some changes in the ECG. What are those changes? A bit differ from right to left side. On the right side of pneumothorax, there is changes in the morphology of the QRS complex, leading to development of right bundle branch block and the T-wave inversion in the chest leads. You see in this ECG. And the left side of pneumothorax, there is right axis deviation is more common, and the reduction of the amplitude of the QRS complexes and poor ROA progression in the chest lead, because on the left side it is more air that is producing insulation effect to prevent the transmission of the electrical impulses. So there is non-progression of the R wave, and as well as there is reduction of the amplitude of the R wave here. But how it differs from tension pneumothorax? You know that tension pneumothorax, there is a valve, one-way valve, and there is accumulation of air and air and air that ultimately produce a state of hypotension and the shock that resulting in the reduction of the coronary blood flow. So the changes are almost similar to those pneumothorax on the right or left side depending on the site, along with myocardial ischemia, resulting in the ECG changes like T-wave inversion. Now we'll shift to hepatobiliary disorder. Among the hepatobiliary disorder, we'll be discussing on acute pancreatitis and the acute cholecystitis. You see the acute pancreatitis who are working in if anybody has experience in the working in the CCU, they almost invariably would encounter the cases of the acute pancreatitis, because the pain of the acute pancreatitis is so severe and it adheres to the back, which may confuse with the cardiac pain. At the same time, these patients presenting with shock. So these two features ultimately confuse with the mimicking the presentation of the acute coronary syndrome. That is very important for us. And sometimes the therapy which are strongly advocated in acute coronary syndrome is contraindicated in acute pancreatitis. In acute pancreatitis, these ischemic ECG changes can produce diagnostic dilemma with the acute coronary syndrome. What are those ECG changes? Again, non-specific STT changes. And in acute pancreatitis, only 40 to 50% of the cases there may be ECG change, and the rest of the 50% cases there may not be any ECG change. diffuse T wave changes only, ST segment elevation mimicking acute myocardial infarction, and due to development of some vagal inhibition or vagal mediated reflex, there may be conduction abnormalities. There is a case report where they found that the acute pancreatitis masquerading as inferior wall myocardial infarction. A 77-year-old man presented for acute chest and back pain with vomiting, with hemodynamics instability, and the new ECG change of ST segment elevation in the contagious leads 2, 3, and AVF mimicking an inferior wall myocardial infarction. And emergent coronary angiograph showed no significant coronary artery anomaly or obstruction. At this ECG changes, they are telling that the T-wave negativity or inversion is the most frequent ECG changes in patients with acute pancreatitis. They studied over about 64 number of acute pancreatitis cases where they found these sorts of ECG changes. So among which the negative T-wave or T-wave inversion is the most frequent changes, along with ST changes in the form of depression, elevation, rate increase or decrease, and the bundle branch block and the junctional rhythm because of vagal mediated inhibition. That is, we call it biliary cardiobiliary reflex or hepatobiliary biliary cardio reflex. What is the how the ECG changes is occurring? We call this cardiobiliary reflex one mechanism. In acute pancreatitis, the proteolytic enzymes may released into the circulation, which may goes to the heart, acting on the myocardium, producing lysis of the myocardial cells. So it may lead to ECG change as well as enzymatic change. There may induction of the systemic inflammatory response, interleukins, and so on other on that may produce some cardiac abnormalities. Concomitant electrolyte disturbances that had to be differentiated because acute pancreatitis produces a lot of electrolyte disturbances in the form of hypokalemia, hypocalcemia, hypomagnesemia, and even hyponatremia. So that has to be considered first. Coronary vasospasm due to systemic inflammatory state. Somehow somebody says the pancreas is close to the diaphragm. It may produce some changes so that in the inferior wall of the heart. Coagulopathy, and lastly, the stress-induced cardiomyopathy. That is important in certain situation where the patient has got severe stress on all the systems of the heart, all the systems of the body, including the heart. So by all these changes, the patient with acute pancreatitis may shows different changes mimicking acute coronary syndrome. Now we'll be talking on acute cholecystitis. Acute cholecystitis and the biliary colic may have sign symptoms similar to those of acute coronary syndrome. Cholecystitis and the cardiovascular disorders share the common risk factors. You see the diabetes, family history, dyslipidemia, these are the common risk factors. And the common sympathetic supply to the heart and the gallbladder is coming from the fifth thoracic spinal segment, so-called cholecystocardiac link. So what are the ECG changes? Due to reflex, there is radiarrhythmias, development of AV blocks, ultimately may culminate into complete AV blocking. There may diffuse non-specific TO inversion as acute pancreatitis, ST segment elevation or depression. We'll see later on. Pathophysiology is unsettled or unknown, but the reflex coronary vasospasm is one possibility, and another one is vagal stimulation, which call it cardiobiliary reflex. This 34-year-old Caucasian female who was referred with symptoms consistent with acute cholecystitis, and electrocardiogram showed unexpected changes with infralateral ST segment elevation indicative of an infralateral myocardial infarct. You see here that the inferior lead, there is mild ST elevation with involvement of the lateral leads, V5 and V6. A 36-year-old white female presented with sudden onset of substernal chest pain, very much confusing with the acute MI, with palpitation and the nausea. 12-lead ECG revealed sinus bradycardia with frequent premature ventricular contraction. You see the COP sign, there is a case report about the COP sign and the complete heart block secondary to acute cholecystitis. A 64-year-old male having symptoms of acute cholecystitis presented in the emergency department with complete heart block with abdominal pain and hypotension due to hemodynamic instability. They do the temporary pacemaker for the support of the patient. You see on the right side of the ECG, right side of the panel. So what is that cough sign? Cough sign is a reflex bradycardia seen in the patient presented with the biliary colic, either choledocholithiasis or cholecystitis, whatever it is. The association between the calculus cholecystitis and the bradycardia was first reported by O'Reilly and Kratmar, and it was known as cough sign, named after the Jessary cough, who was the first documented patient having this cardiobiliary reflex. Bradycardia in acute cholecystitis may be due to vagally mediated cardiobiliary reflex. Both heart and the gallbladder are innervated by vagus nerve and T4 and T6 spinal roots, T4, even T5 and T6 spinal roots. A study by Kaufman et al. Demonstrated that these reflexes can be inhibited by giving atropine to patients with gallstone disease. So it is vagally mediated. Atropine is a vagolytic agent. Now we'll shift to our discussion on the acute stroke. Stroke may be ischemic stroke, may be hemorrhagic stroke. The ECG changes frequently observed in acute stroke, either ischemic or hemorrhagic, but these are often benign and reversible. Cardiovascular effects of stroke are moderated by concomitant or pre-existent cardiac diseases and electrolyte disturbances again. Hemorrhagic stroke, particularly subarachnoid hemorrhage, is frequently accompanied by a variety of ECG changes. And the suspicion of intracranial hemorrhage is a contraindication of thrombolytic therapy, anticoagulant therapy, even antiplatelet therapy. So diagnosis should be based on judgment, quite depending on your depth of the knowledge and decision, because the treatment may differ in both the case, and the treatment of acute myocardial infarction with thrombolytic agents may produce disastrous consequences to the patient who is suffering from the acute stroke. So what are those changes? Ischemic ECG changes in the form of the ST elevation, ST depression, deep T wave inversion, and the appearance of the Q wave. There may be QT prolongation, arrhythmias in the form of supraventricular arrhythmia particularly, and the bradycardia also, and AV blocks. Abnormal UF, either prominent or inverted, and some patient may present with Brugada-like ECG changes. This type of ECG changes is possible. This is a report study done in 2014 showing the spectrum of the ECG changes in cerebrovascular diseases in the acute cases. So these are few ECG change you will see here. You see the T inversion is here is broad Vijari shaped T inversion. In almost all the leads are affected by this T wave inversion. Here there is concomitant QT prolongation here, and the appearances of the QRS complexes in the anteroceptal leads are mimicking the spiked helmet sign. These are the helmet which were using by the German army men at that time. There is a middle, there is a spike, and other there is convexities. These are called spiked helmet sign. These are again ECG. These are in the first day, 3 days later on, and on the 4th day, there is almost normalization of the ECG pattern, except few T wave inversion. This patient presented with a sudden right-sided weakness and ophthalmoplegia that was resolving upon presentation to the emergency department. You see that there are Q waves in the anteroceptal, the V1 and V2, as well as some sorts of ST elevation. CT angiogram was done to avoid the confusion. The patient's symptoms are resolved and no intervention was taken out. MRI confirmed there is small stroke, ischemic. How in acute stroke there may be ECG changes. Important one is the autonomic dysregulation. As the center, all the vital centers are situated in the brain. So if there is any disturbance in the function of the brain, hypothalamus, insular cortex, they lead to some changes, autonomic changes. And mostly sustained sympathetic stimulation that results in structural damage to the myocardium, either due to local release of the catecholamines or by systemic release of the catecholamines. And some says there is also increased parasympathetic activity that sometimes may produce sinus bradycardia and the heart blocks. And there is arrhythmogenesis center in the insular cortex, which may, when activated, may produce some sorts of arrhythmia, tachy or bradyarrhythmias. Again, the electrolyte composition due to severe cerebrovascular accidents, there may be inappropriate ADH release, there may be vomiting, there may be reduced intake, so there may be electrolyte imbalances, and that may produce ECG changes. And again, stress-induced cardiomyopathy, an important consideration for us. Now, gigantic tube inversion or cerebral TIF নিয়ে দুই চারটা কথা এটা প্রায় আমাদের কনফিউশন তৈরি করে। The transient deep inverted TIF in the setting of the stroke commonly referred to as cerebral TIF. TIF inversion are actually graded. You know, the TIF inversion refers to TIF inversion that are between 1 to 5 millimeter in depth. When we call it deep when it is more than 5 millimeter or in between 5 to 10 millimeter depth. And gigantic TIF inversion we call it when the depth of the TIF exceeds 10 millimeter in the chest lead. Deep or gigantic symmetrical TIF inversion may be found up to 30% of the patient with acute hemorrhagic stroke, not all the cases. The TIF inversion looks bizarre and usually diffuse in distribution rather than limited to one ECG or in one arterial territory. So it is in contrast to ischemic change in acute coronary syndrome, that it does not follow the coronary artery distribution and rather it is diffuse in distribution, usually associated with prolongation of the QT interval that again confused with acute coronary syndrome, may be associated with transient LV valve motion abnormalities. It is very significant to if there is any ECG change along with valve motion abnormalities, does not necessarily to have only cardiac abnormalities. Rather, the neurogenic factors may also lead to temporary LV valve abnormalities. The cause is unknown, and which we have already discussed that autonomic dysregulation and probably increased sympathetic discharge from the hypothalamus may be responsible for this ECG change. Now we are talking about the raised intracranial pressure. Raised intracranial pressure may occur in subarachnoid hemorrhage, intraparenchymal hemorrhage, massive ischemic stroke leading to cerebral edema, traumatic brain injury, and cerebral metastasis. And these changes we have already discussed, and now we'll see few ECG changes in raised intracranial pressure, how they are changing the ECG. Again, these are, you see the cerebral TIFs here, and this is a ECG of subarachnoid hemorrhage. And this again, giant TIF inversion with prolonged QT. These are also, you are seeing the terminal TIF inversion with QT prolongation, subarachnoid hemorrhage. And this ECG, this type of ECG changes may confuse with the acute myocardial infarction. 18-year-old girl with severe traumatic brain injury and massively raised intracranial pressure. There is widespread ST elevation with a pericarditis-like morphology and no reciprocal change. She had no cardiac injury, no pathogenesis to explain the ST elevation. The ST segment normalized as the intracranial pressure came under control. This is a term which is called the neurogenic stunned myocardium. We have to know about that. Neurogenic stunned myocardium or NSM is defined as the myocardial injury and dysfunction of the sudden onset occurring after various types of acute brain injury. And we have a strong doubt when the patient with raised intracranial pressure or intracranial pathology has got the evidence of acute left ventricular failure with pulmonary edema, hypotension progressing to development of cardiogenic shock and development of various arrhythmias. So what are those ECG changes that may happen? We have already discussed ST segment change, T wave change, new wave, and prolonged QT interval. And these biochemical changes will again make confusion with acute coronary syndrome. There will be increased CKMB, increased tropi, increased NT-proBNP level as there is LV dysfunction and stretch. Echo will show both systole and diastole dysfunction resulting from impaired valve motion abnormalities. And pathogenesis we have already discussed, but one thing important here, the myocardial injury induced by local catecholamine release from the nerve endings in the myocardium is an important factor also. So what is the treatment? Basically, we have to observe this as a cardiologist, but main focus should be give attention on the underlying disease treatment. It is a fully reversible condition so far cardiac pathology concerned. If the patient survives, an improvement in the neurologic pathology leads to rapid improvement of the cardiac function and full recovery. What is the importance for this neurologically stunned myocardium status? Difficult to distinguish this status from acute coronary syndrome. And awareness of the existence of the neurogenic stunned myocardium may reduce the diagnostic errors and will optimize the treatment. Now we'll tell about the thermal disorders, few slides. Normal temperature 97.7 to 99.5. Hypothermia we call when it less than 95 degree Fahrenheit. Fever we call it when it exceeds 99.5. And hypothermia also we call when it exceeds 99.5. But the basic difference between the high fever and the hyperthermia is the mechanism. In hyperthermia, there will be temperature regulation point. The hypothalamus is a temperature regulating point that does not take part in the production of the heat. But in case of fever, the temperature regulation center acts and produces fever. But in hyperthermia, there is loss of temperature regulation system. What is hypothermia? Mild, moderate, and severe. We can divide it in our context. It is not very important. We'll go very quick through this slides. Hypothermia may produce the following ECG abnormalities: bradyarrhythmia, Osborne waves, prolonged PR, QRS and QT interval, shivering artifact, ventricular ectopics, cardiac arrest due to VTVF or asystole. Bradyarrhythmia in the form of sinus brady, atrial fibrillation is slow ventricular response, slow junctional rhythm, varying risk of AV block. How they are producing: delayed activation of the repolarizing potassium current, delayed inactivation of the sodium current, delayed inactivation of the inward calcium current. So all this produces these sorts of bradyarrhythmias and ECG changes. You see this patient has got severe sinus brady due to hypothermia. You see the atrial fibrillation with slow ventricular response. You see the bradycardia with presence of Osborne wave and the shivering artifact. You see the J waves, which ultimately may lead to development of the Osborne waves. This is moderate hypothermia. There is more prominent J wave and bradycardia. This is severe hypothermia, where there is very much prominent Osborne waves here. It is most prominent in the V4 and the V4 loops. And prolonged QT in severe hypothermia. Shivering effect, you see the changes are only sinus brady and the shivering artifact is here. Hyperthermia, when the core temperature exceeds that normally maintained by a homeostatic mechanism. Uncontrolled hyperthermia differs from the fever that the body temperature is elevated above the thermoregulatory set point due to excessive heat production and or insufficient heat dissipation. These are more important than the hypothermia in the context of Bangladesh. ECG change is sinus tachycardia, diffuse STT change, prolonged QT interval, and sometimes Bogada-like ECG changes may happen in hyperthermia. You see, this is the ECG tracing from a patient with hyperthermia. There are changes. You see the rate is increased. You see the gross ST segment depression and the T wave inversion, and you calculate the ECG QT interval. You see that there is a prolonged QT interval. The elderly woman presents with altered mental status. She was found by her family lying on her bed in her apartment on a hot summer day. You see the sinus tachycardia with rate 124, normal axis, QT is prolonged. There is elevation of the ST segment in the V1, V2. So that mimics the acute anteroseptal myocardial infarction. Active patient within 1 hour, temperature came down to 101 and the ECG was repeated. You see all the changes has been resolved except the incomplete right bundle branch block. It is hypothesized that the rate of sodium channel inactivation can be temperature sensitive and the fever can impair the conductance to the sodium channels. So pregnancy, now the pregnancy, whatever changes, we have got 1 or 2 slides here. Pregnancy affects all the functions of the maternal body and brings about remarkable changes in the cardiovascular changes. It may also cause changes in the electrocardiogram, which can be confused with certain heart diseases. You see the heart rate may be increased. There will be appearance of the Q wave in the lead 3. There will be reduction of the PR interval and there will be Qrs Axis deviation. We'll see later on how they are occurring or what is the mechanism, physiological mechanism to explain all the changes. Heart rate is increased because there is fall in the stroke volume resulting from the inferior vena cava compression. So that leads to compensatory increase in the heart rate. Is there any change in the time interval like PR, QRS interval? No. Yes, there is change. There is intervals are decreased, but it is due to shortening of the AB conductance and the resultant tachycardia. What is about the Qrs axis? Variable changes may happen. It may remain normal, or it may have patient may have left axis deviation because of raising of the diaphragm as the pregnancy advances, and this effect is most pronounced in the last trimester of the pregnancy. The amplitude, no change in the amplitude of the P wave, QRS, or T wave. Is there any change in the Q wave? Yes, there may be presence of Q wave in the lead 3 particularly, or even in lead 2 even, due to altered position of the heart, an increase in the circulating vasopressor agent, or may reflect diaphragmatic changes that have been associated with pregnancy. T-wave typically flat or inverted in lead 3 and V2. It is due to increased workload on the heart due to temporary increased blood volume during pregnancy, which may cause temporary ischemia. There is no ischemia. ST segment may be depressed in the chest and the limb leads during exercise. The segment is changed due to outward and upward shift of the cardiac apex by the enlarging uterus. QT interval, basically cardiac QT interval is increased, but total QT interval remains unchanged. This increase in the corrected QT interval may be due to increase in the heart rate. There may be rhythm disturbance, and it is often due to stress related or mechanical irritation of the heart from below by the enlarging uterus. You see the ECG changes before and after pregnancy. Here you are seeing the changes in the there is T-wave inversion in the chest lead, and you see the shortening of the peer interval in compared to pre-pregnancy level, and there is appearance of the Q wave. No, there is no Q wave here. There's some sorts of ST segment depression in the lead 2, 3, and AVF. And this is the last slide. Thank you everybody for taking the constraint of a boring presentation. Thank you everybody. Thank you, sir.
Very interesting presentation. Khalequzzaman,
Sir.
I would say it's a very interesting presentation.
Really excellent presentation. Excellent.
Hafiz Bhai, Rafi question na? Hafiz Bhai, would you comment?
Yes, it is an excellent presentation because this ST elevation and then all other EKG changes. Sometimes we encounter and then bigger problem in the US is the ST elevation, particularly they call ST elevation MI, and now we'll have to move the cath lab, take the patient. So it is important to recognize couple of things. ST elevation in PE, extremely rare, but it is a bad prognosis. And typically, I'll show some examples later that this is shoulder down ST elevation. Very important to recognize the pattern of the ST elevation and then put it in the context of the clinical presentation. Somebody with the PEA arrest and ST elevation and shoulder down ST elevation, that's not STEMI, that's PE. So because remember that MI, usual arrhythmia is BFib. If there is a PEA arrest and shoulder down ST elevation, 2 + 2 is 4. Get a CTA coronary first, exclude PE. Otherwise, if you rush to the cath lab, you will see coronary is normal. Now we are in deep trouble. Patient may code with another PEA in the cath lab. Pneumonectomy can cause you similar changes following the lung resection, transplant, lung transplant centers, they often see this. Echo is helpful. Sometimes you may need to do other modalities such as put a probe down, get a TE also, and that may helpful. My rule for the fellows, if the EKG looks ugly, the uglier the EKG, it is less likely coronary. The uglier the EKG, it is less likely coronary.
Fine tips.
And then another important thing that in the setting of stroke or subarachnoid hemorrhage, you see the T inversions. Often you see the ST elevations, and then troponin is like 7, and there is a dilemma that what do you do? And you said nicely, absolutely brilliantly that it can be explained by a variety of things, including stress cardiomyopathy, and then dysregulation in the sympathetic center, and then um, we see that also with the cervical spine surgery. But what I would say that if you can do an echo, particularly intubated patient, we use definitely. We often recognize that there is a typical apical ballooning, and we don't take to the cath lab. But again, I can't thank you more. This is a very organized, brilliant presentation.
Exactly, exactly. Arun, do you want to have some
Thank you,
comment?
sir.
I mean, you hardly see this sort of lectures with a specific disease. What we hear lecture is other like ischemia, electrolyte imbalance. This was a fantastic lecture. I mean, after seeing this lecture, when you get any patients now, you broaden your knowledge and you now start thinking, because they're saying, eyes do not see what mind does not know. If you don't have your differential diagnosis, then you will not be thinking anything else. So like once I have a experience, COVID time, patient had typical chest pain and then some subtle ECG changes. Troponin was positive, we took him to cath lab. Did an angiogram, was normal. After 1 or 2 hours, he has severe chest pain radiating towards the back. Did an angiogram, there was a dissection. So we missed the history. We were guided by some ECG changes. Had we taken history, we could not have missed. So these are very important things we should remember, and very important. And thank you, ECG study group, Dr. Wadud, Atahar, Rafiq sir, and all the speakers bringing good topics and broadening our knowledge. This is wonderful.
Arun, we are waiting for one lecture from you.
Okay.
The
Yes,
sub.
I think there are not too much questions except one question. What is the mechanism of bradycardia or complete heart block in obstructive jaundice? Dr. Khalequzzaman.
I have told that there is a reflex or a sign, or Kopp sign or reflex. This is due to reflex development of the bradycardia, vagus nerve supplying the biliary apparatus, and at the same time vagus nerve supplying the heart. The effects of the vagus nerve stimulation over the heart is bradycardia and the bradyarrhythmias. And this reflex arc, the pain stimulates the arc, it goes to the vagal center, and there is reflex will be to slow down the heart through the vagus stimulation. This is called this is called cardiobiliary reflex. That is why the patient developed bradycardia and sometimes AV blocks, and may ultimately lead to even development of complete heart block even for a temporary period.
May I add one thing here, because that can happen with any acute abdominal catastrophe, right? Because of the severe pain. But uniquely, obstructive jaundice, there is actual bile salt deposition in the
Again,
conduction.
right, sir. Bile salt.
Yeah, and therefore that can give you complete heart block. That is
Right.
uniquely
Right,
a
sir.
phenomenon with obstructive jaundice.
In chronic cases.
Can I add something? In Dhaka Medical College, as it is a multidisciplinary hospital, we often get patients with acute cholecystitis or pancreatitis misdiagnosed as inferior MI or unstable angina with inferior wall ischemia. But one thing I have taught my students, have a look at the patient. You will find out if the patient's respiratory movement, diaphragm is not moving, that abdomen is still, it's not a cardiac problem. It's an abdominal problem mimicking cardiac problem. And because all the cardiac patients have normal respiratory movement, I have often described my students by just saying that patient is not cardiac. Go have a look for the Murphy's sign, and they have found that it's Murphy's sign positive. And they become the, sir, how can you say? But have a look. You should always remember that. That's a very helpful thing.
So, Hafiz bhai, I want to add one thing.
Yeah.
Hello.
Yes.
Sir, শোনা যাচ্ছে।
Acha, what actually Chowdhury Hafiz bhai actually added to our Khalequzzaman's theory that the reflex mechanism, that is also there is a chance of the deposition, particularly the bile salt deposition, And regarding my comment is regarding this deposition, particularly not only the bile salt and other things like the sarcoid and other, particularly hypothyroidism, when there is a chances of the deposition usually happens infranodal, that is around the his bundle, and this group of the patient, when they develop the bradycardia and the heart block, usually it is the white complex. So this is one of the clue. This is one of the clue, that is the, you will getting these kinds of the finding along with the infranodal features, that is the white complex. Then there is a strong suspicion this may be related to the deposition of something like the, in this case like the bile salt.
Khalequzzaman, can I ask you, in the ECG you have shown for cord pulmonale, there was tall peak P wave, but in the V1, there's deep P wave inversion, inverted P wave.
One.
That indicates as if the patient is having left atrial enlargement. Can you explain it?
And there is one ECG, there was like that change.
Can you explanation?
Yes, I cannot explain it. Can you explain?
Let me see something. My ECG lead position is fixed in the fourth interstitial space V1, V2. But in case of cord pulmonale or emphysema, the heart is very low down. Your atria, everything, because the pericardium is fixed with the diaphragm. If the diaphragm is low down, the whole thing gets down. The heart becomes tubular. So the atria and everything becomes very low down from the usual position of the leads. So consider that even from the SA node, the impulse is traveling to the AV node and to the ventricles. It's going down away from this V1, V2. So that's why you get a inverted P wave in there. It actually do not mean that the left atrium is enlarged.
Interesting, sir.
The patient have very low down diaphragm.
Excellent, nice explanation, Firoz.
Thank you, sir. Thank you, sir. I think Dr. Khalequzzaman has given a brilliant lecture, and he has it's an eye-opening lecture for all of us, including the fellows. The message, I think, which he wanted to convey to our young generation is that each and every ECG change has got multiple differential diagnoses, and in case of non-cardiac cases, there may be ECG changes. So you shouldn't be puzzled with the ECG changes when you are called by the non-cardiac disease condition. Now we can move on to our next session. It is Professor Arun Maske. He's from Department of Cardiology, Shahid Gangalal National Heart Center, Kathmandu, Nepal, and he's another identity is he's from NICVD. He had his MD cardiology degree from NICVD, so he's one of us. May I request Professor Arun Maske to present his case?
Whether Ropik sir is with us or not? Whether Ropik sir?
He's not in the camera, sir.
I'm listening to the lecture.
Okay, sir. Okay.
Sir, it is we are searching as because sir, it is Arun Maski's.
Yes, definitely. I'm here. Yes.
Well, I'm not a electrophysiologist to interpret all those ECGs, so I'll be presenting one interesting case. Maybe something we may have missed or something we should not have been done. I'll just put a presentation and take opinion from the learned panelists and electrophysiologists. This is a 71 years male. He's a retired police officer. He was referred for bradycardia. He had no risk factors. His echo showed normal ejection fraction, no history of syncope. He had past history of dizziness, which was very vague, otherwise asymptomatic. He was referred by, he went to one GP, and this was the reason why he was referred, because he had a heart rate was around 30, 32. Sinus brady. What we can see here is inverted P waves in inferior leads and V5 and V6. So I would be happy to get expert comment from our panelists, our officer, what should we do this patient. And during observation, he was kept in hospital for 5 or 6 days. During daytime, his heart rate, though we could not record his heart rate with the ECG, but monitor showed heart rate around, sometimes around 28 beats per minute. Otherwise, it is asymptomatic. So any comment on this ECG?
I would not call it sinus bradycardia because it's not, the P wave is not sinusoid.
Okay.
By rate, it is
sinus
the,
from-
most likely the junctional.
Junctional.
It's not junctional because PR
So,
is
yeah.
low.
Maybe left
আতার ভাই আর রফিক ভাই একটু পরে বলেন, কারণ আপনারা তো ইপি গাইস, যারা প্লামাদের আগে বলতে দেন।
আচ্ছা বলেন।
Question is, আমার question হলো হাফিজ, এটা কি acute MI কিনা?
না,
Angiogram.
Does it need coronary angiogram?
this is a ectopic atrial rhythm.
Yes, exactly.
But the question is, what is the response with exertion?
And it's from the left atrium, low left atrium, because the left lateral leads shows negative P waves, and V1, V2 showing upright. P
এগুলো
waves.
ওদেরকে মারামারি করতে দাও, ইপি কে। Dr. Arun Maski, Professor Arun Maski,
Yeah.
do you have any more info, like when the patient exerts, with what happens to the?
No, let me, I have full information of this patient. Retrospectively, we analyzed everything and we came to a correct diagnosis. But
Okay.
before that, I'd be happy to get comments from our electrophysiologist so that we can get a good idea, because I'm not an electrophysiologist. So Rafiq sir, what would be, because
Well, I
in
mean, this is a 77-year-old, right?
72.
72,
72-year-old male with history of syncope and pre-syncope.
no history of syncope, no history of pre-syncope. Only
Just
dizziness.
Yes.
Some history of dizziness, is a retired police officer
Okay.
and referred because of this ECG.
Okay.
Past history of some dizziness, otherwise asymptomatic. No risk factors. Ejection fraction is normal.
The heart rate is 42 beats per minute. This is a left atrial rhythm. So the problem is the sinus function is missing, even at this rate. So there is no question there is sinus node dysfunction in this patient. I mean, if this rate was faster and there was no sinus P wave, I could have said, well, the left atrial activity is suppressing the P wave. That is not the case. So that's one problem. And during telemetry monitoring, of course, you had bradycardia. I mean, my diagnosis, I mean, I will be tilting towards diagnosis of sick sinus syndrome. The question is what to do with it. That will be the question. If he had syncope, I will not do any more workup or anything, just put a permanent pacemaker in.
Yes.
72-year-old male who is otherwise healthy is probably sick sinus syndrome. There's no question about that. You can put this patient on a treadmill to see what happens with the heart rate. If you see, I doubt very much that his heart rate has gone up. Did you do a treadmill stress test on this
Yeah, I've
patient?
done everything.
And
Yeah.
what did you find?
Yeah, I'll show you sequentially. But during daytime, when we are monitoring these patients, the heart rate goes up to 28. beats
Down to
per
20.
minute.
Yeah,
So what to
28
do
beats
now?
per.
Wake up period 28.
A wake up period 28. That was the worrisome.
Yes.
Though I could not find, we could not record that ECG. So by the time we record, it becomes around 32, 33. So that was one concern.
So when that happens
During
Professor Maski,
daytime.
during daytime, do you lose the P wave or still has the same P wave QRS complex?
It was in the monitor. So the duty nursing staff was saying this, it has dropped to 28. So it's not recorded because we
And
do
heart
not-
rate 28, unlikely to be the atrial rhythm, sir. It should be the escape rhythm
Function.
from somewhere else. That is the other than the atrium.
Arun, was there any change in the QS complexes? They
because
didn't.
it's not recorded. So I believe it's no changes, I think. I mean, I cannot tell because this is from the nursing staff when they were doing from the monitor, they were saying it drops sometimes up to 28 in the
The
during
echo is
daytime.
normal, right?
Echo is
And
normal.
Is
No
the
risk
patient
factors.
on any medication, beta blocker,
No,
calcium
no,
channel blocker?
not on any medications.
Okay, so
Yeah, Arun Maski, EAP is normal, whether LV dilatation is present or not.
No, normal ejection fraction.
The LV,
Only,
LV
only is coronary sinus was dilated.
Or go ahead. Go.
Okay.
Next information.
Yeah. So this is a ECG in different period of time. So after a discussion, we thought, though the patient doesn't have syncope, based on this ECG, we thought probably he would be well enough with pacemaker. So that's what we decided, maybe right or wrong, which we can discuss later on. And then retrospectively,
You go after the sinus dilatation. Any further evaluation of the sinus of valsalva aneurysm or anything that you excluded?
no, actually what happened was whenever, because of COVID time, it's a practical, the patient comes to emergency, then we do a echo screening. Until and unless we have any other things, we do not do full echo. And this patient was reported nothing else but normal echo in the emergency department. They did a full echo screening. And retrospectively, we try to do things, then we could come to a diagnosis. And as you have asked the question, we did treadmill test in this patient. There was no chronotropic incompetence.
And it's a sinus rhythm.
Yeah. So that's what guided us. And this was a Holter reporting of this patients. I don't know whether you can see it properly or not.
We can see.
Well, this is a patient, even though he has good chronotropic response, his findings are consistent with sick sinus syndrome.
Yes.
And I will probably put a pacemaker in this patient or keep him in close up. I will tell a patient like this, either you get a pacemaker today or within the next few years. If this was a young person, I would wait. 72-year-old with some dizziness and daytime marked bradycardia with atrial rhythm, this patient will benefit from a pacemaker. That will be our choice here.
Sir, can I ask a question?
Sir,
What
I want to explain, sir.
you will accept as not important at night time, during sleep time? What level of bradycardia you will accept that is not going to be a problem?
Are you asking me the question?
Yes, sir.
Yeah. Well, nighttime bradycardia, I'll tell you. Arun, by the way, thyroid function, what was it? Was it normal?
Normal.
Yeah. Nighttime bradycardia does not bother me at all. I have seen patients 10, 15 second pause, and I did not put pacemaker in. So that is not the issue. Issue is daytime awake bradycardia, awake junctional atrial bradycardia in this patient is concerning.
Vik bhai, I have a question.
That's why
Nighttime bradycardia.
the
When-
only one from you about
Go
this.
ahead.
That's why I'm asking you the question. You have taught me long ago about this, but the audience should, we should
Yes.
not pay too much attention if we get nighttime bradycardia, if the patient do not have any symptoms,
Yes.
but daytime, wake time bradycardia is important.
The other thing is the threshold for pacemaker. The older the patient is, less threshold I have for pacemaker. The younger the person is, I have more threshold for pacemaker. Even if somebody needs a pacemaker, we try to delay as much as possible. And please be important. Let's say I do a Holter monitor and somebody marks dizziness or near syncope with a heart rate of 45 during daytime. What I'm going to look at other part of the tracing when at other time the heart rate was 45, whether he was symptomatic or not. So that is important, because if you look at Holter monitor over during daytime, sometimes at heart rate 45 he has dizziness, sometimes he does not have dizziness. That means that bradycardia is not the problem. Something else is the problem. So please make sure that when you look at Holter, you look at not only at the symptomatic period, you look at equivalent heart rate at other time while the patient is awake, whether the patient is symptomatic or not. Otherwise, you will put a pacemaker in and the patient will not benefit. I mean, this patient, Arun, has the problem because patient never passed out. I'm sure if the patient has syncope, we will not be talking about it at all.
Exactly.
The other thing that we can do, we can check the sinus node function. And if that is abnormal, then definitely put a pacemaker in. But clinically, I think this patient will benefit from pacemaker. We will probably not do much workup on this patient with dizziness and that kind of bradycardia.
This is
Rovik I had this question to you that, you know, you can do sinus node dysfunction test in the EP lab. But for example, Bjornborg, tennis player, bradycardia, do they go in athletes? Do they go into ectopic atrial rhythm when they are bradycardic?
Oh, Bjorn Borg's heart rate was 30, resting heart rate was 38. I think, Hafiz, you missed my question.
That was sinus rhythm. That was
Yes,
sinus rhythm.
Sinus rhythm. And when he would play like 6 sets of tennis, his heart rate will be 78.
Right. But this guy is a policeman. He's not Bjorn Borg.
Yes. But I mean, he's 72. I mean, he's a fit guy. But I don't think this is.
Yes.
But this rhythm is not sinus bradycardia. This is ectopic
Yes,
atrial.
yes, absolutely.
That is the problem.
Sir,
I mean-
actually, sir, after seeing the first two ECGs, that is ECG number 1 and ECG number 2, is there any role of the ETT, sir? This is academic discussion, no problem. But for the clinical evaluation, is there any role of PTT, sir? That is stress test in this case. After seeing the ECG number 1 and ECG number 2.
To see the functional chronotropic competence.
Yes.
Yeah.
So we look at two things. Let's say this patient came to me with sinus bradycardia of 45 beats per minute. His heart rate used to be 70 before. And he has occasional dizziness, he has profound fatigue. And I'm trying to find out if that is related to the heart rate. And that patient, if I put on treadmill and the heart rate goes to 110, 120, I will say he will not benefit from pacemaker to relieve his fatigue. On the other hand, I put him on treadmill, he walks for only 2 minutes, gets short of breath, and his heart rate is like 75.
Yeah.
This patient will benefit for symptom of fatigue. In this patient, he doesn't have chronotropic incontinence because he does not have exercise intolerance anyway. The question is, will it happen one day that he will become markedly bradycardic, will have a pause and pass out? So in this patient's case, implantation of pacemaker will be to prevent bradycardia-related symptoms, mainly syncope.
next. This is a halter, and sorry, this is same ECG after some time, and just for academic purpose, as Rafiq sir was right to say, we use a pacemaker even if the patient is bradycardia, if patient is symptomatic or sick sinus syndrome, even if the pause is more than 6 seconds, the current recommendation is do pacemaker if the patient has history of syncope. So this patient does not have history of syncope, but as Rafiq sir was rightly pointed out, this is not a young man. So this was a 72 years old gentleman. He may need pacemaker in future, maybe here, now, or there. So we took him the cath lab, rightly or wrongly. So I cannot play this picture. I don't know why. It's playing, I think. So what we can find here is the right side we could not access. Well, first we tried the left because normally we tried through left axis. What we can see here is, it's not playing here. There's one dilated channel here. This is posterior left superior vena cava. From coronary sinus, it's moving into, sorry, it's not playing. I don't know why.
It was, you have shown me it was playing at the time.
Yeah, it was playing. I tried, it was playing. I don't know why it's not playing here. It's moving.
So here,
sorry.
persistent left superior vena cava.
And yeah, it should play actually. I don't know why it's not playing.
All right, show us the echo.
It's hang, I think.
Can you show us the echo?
No, it's hang now. I cannot move.
Sir, no
Okay.
problem.
No, this is a copy. I have done an echo of this patient. I could not bring load the pictures. This is one of the echocardiograph which I have copied from European Heart Journal. So what they have done is, this is a dilated coronary sinus. The picture exactly same like this one. I have recorded this one, but I could not bring those records. So they have recorded, they have injected from left arm, and then through the coronary sinus, it's going into right atrium. In the right arm also, they have injected and it's going through coronary sinus into right arm. So this is a case of persistent left superior vena cava and absent right coronary artery. So this will give you a good picture. I've taken a CT scan of this patient. So from injecting from right side, it's going from here. This is a vertical vein going into persistent left superior vena cava, coronary sinus into right atrium. And sorry. It's hang, I think.
Yeah.
So yeah. So these are the dilated coronary sinus, right atrium and right ventricle. So I reviewed the literatures. This is from European Heart Journal, same which I did echo. So persistent left superior vena cava occurs in 0.3 to 0.5% of general populations. Coexistent absence of right SVC is caused by obliteration of the right cardinal vein during embryogenesis and is extremely rare. I think if I can play this picture.
Computer has its own mind.
No, I had this picture. I've copied those pictures. I played that pictures. I don't know why it's not playing. It was playing.
That would have been very nice if you can see that.
Persistent left. Yeah, we can see it.
No, Karan, prison got this correct.
All right. Don't try. All right.
Can you go to slideshow? Maybe if you go to slideshow. I think you will have to go to slideshow. You are not in slideshow mode. On the if you see the slideshow on the top right, if you go to the right, slideshow.
Right.
Slideshow.
After animation, transition, animation, select.
This one.
Yeah. Okay. And then from the current slide, if you go to second one, yes. Click that and try it now. See what happens. Oh, no, I think the software did not load. So that's fine. It's the left superior vena cava, persistent left superior vena cava.
All right. Or go ahead with the other information.
I can stop share this one.
Finish, Varun.
Yeah, finish my. This is.
So whether he put the pacemaker?
No, actually, then we retrospectively analyze, and we decided because this is left persistent superior vena cava, and we left that patient on cath lab and said we would review. And since this patient would require pacemaker, as Rafiq sir was saying, then we discussed with the patient and said, you will require pacemaker, not now, but once you have symptoms. So this patient is on regular follow-up. So This is a ECG follow-up after 1 week after discharge. Any comments, sir?
Can you show us?
Yeah, this is the
You are not sharing the screen.
not sharing screen. Okay, I'll
Oh,
share
you
the
have to
screen.
share it.
Share screen share, please.
Okay, just a second. Okay, can you see this screen
Yes,
now?
yes.
So this is after a week after discharge is ECG.
Sure. I think that is not an unreasonable plan for two reasons. One, patient is not that symptomatic. And technically, if you have not done left superior vena cava before, it is good to have somebody who has done it. In my 35 years, I've done 5 so far. I mean, 3 was my case and 2 were 2 other physicians got it and they called me. And it's something a little tricky, but once you get what you do, you put a lead, it goes from the coronary sinus and you can put an active lead in the atrium. And then you go into the right ventricle, you have to carve the stylet in a funny hockey stick shape. And you can prolapse the lead into the right ventricle to put the atrial lead, put the ventricular lead. So I think this is an acceptable decision on this patient. You can keep following the patient. If you see him every 6 months and follow his heart rate to see what happens.
If you plan to put a pacemaker, what will be the programming?
But the programming will be, we have different kind of programming. I'll program DDD with a long AV delay, so it paces in the atrium mainly. But also there are pacemakers where they switch between AAI and DDD. So when patients have conduction, they will only pace the atrium. And when there is no conduction, they will pace dual chamber. So you can program that way also, manage ventricular pacing.
In this case, I think there is a component of physician fear, right? I think so. If we are thinking that, whether he will be okay, 77 bradycardia, ectopic atrial rhythm, but we have no document that he goes into higher grade of block. So do you think in this situation, leadless pacemaker may be a backup alternative?
Oh, yeah, sure. The question is, that's the question of technology, that whether you want to put a leadless pacemaker in it or not.
I'm thinking about persistent left superior vena cava. Technically, all the EP will not be savvy. So in a compromise, maybe a leadless.
Oh, sure, leadless. But I think doing through the coronary sinus is, intervention guys are doing intervention in complex places where I will not even want to go. This is doable case with a lead, but leadless pacemaker is also a choice. But then again, that comes to the Hafiz, you have to understand the cost of these pacemakers.
Yes.
In Bangladesh, a leadless pacemaker will cost 10 lakh rupees, takas, and a regular VVI pacemaker will cost 60,000 to a lakh. So that's a huge price. I'm sure it's same in Nepal, that in countries like Nepal and Bangladesh, probably putting a pacemaker with lead will be much cheaper then. So if we are concerned about the cost in this patient, you can decide to put a single chamber atrial pacemaker if the AV conduction is good.
I have done left partial superior vena cava pacemaker, sir.
Yeah. The atrial lead is not a problem. Actually, atrial lead is easy even because you make a big curve and it goes into the appendage. It is the ventricle, huh?
More easy.
Yeah, more easy. It is the ventricular lead that is actually a little tricky. Arun, thank you. This is a good case.
Excellent, sir. Firoz.
Yes, sir. I think we should move on to the next session. Our next speaker is Professor Chowdhury Hafizul Hassan. He is the clinical professor of medicine in the University of Nevada School of Medicine, and is also director of cardiac catheterization laboratories and cardiovascular research at the University Medical Center. May I request Professor Chowdhury Hafizul Hassan, sir, for his presentation.
Can you see my screen?
Yes, we can see.
So I don't know how much time we have, but I'm going to focus on the EKG basics and then beyond. But even more importantly, we'll add some assessment and clinical management, because that is really, really important. Let me see. I put up the interventional part. Sorry, let me get the other file. Share screen. Give me 1 second. So the way I look at the EKG, because all these senior attendings that I was trained with, they are too much into EKGs, but I look at EKG for 2 reasons. 1, patient management, and 2 is the passing the board. If you cannot pass the board, you cannot read the EKGs, you cannot pass the board. But EKG should be a broad-based, as Professor Khalequzzaman said, that you have to have a broad mind that this can be present in this condition, so that you don't spend too much money looking for expensive, invasive things. So let's start. Very simple EKGs. 47-year-old presents with chest pain and shortness of breath. And Rafiq Bhai, I follow Rafiq Bhai's format. Please answer the A, B, C, and D.
You have to share screen.
Okay, sorry. Can you see now?
Not yet.
Not yet, sir.
You cannot see?
No.
We have to share the screen.
Where is the ECG?
1 second. Huh?
But we saw the first slide.
No, I think, I don't know why it is not taking it. One second. How do I get this?
Yes, it's coming.
It's coming now?
Not yet. It's showing your June. Then go for.
Yeah.
Right.
Can you see now?
Yeah,
Yes.
No, it's gone. It's gone.
So share screen, right? I click share screen.
You have to download it, share screen, and from the screen, you choose which slide you want to show.
Screen share, then file.
Can you see that now?
Yes.
You can see you. You can see the screen. You can go for the slideshow.
Yeah, you can go. See that now?
Yes, we can see.
Yes.
Okay.
Okay, so what is their diagnosis? 47-year-old presents with chest pain, shortness of breath. I'll go for a rapid fire, maybe 10-15 minutes. I think it is getting late.
Now, do you have poll? A, B, C, D?
We are seeing your first slide. Go for the next.
The answers are in the bottom.
Firoz,
Yes.
Firoz, you can ask for the poll quickly.
Rigu, you can show the poll box.
Yes, sir. Give us a moment. We are starting the poll.
Quickly.
By this time, we can read out the things because
So
the
sinus rhythm, ischemic changes, sinus rhythm, non-specific ST changes, limb lead reversal, not dextrocardia, and dextrocardia. So I will tell you, because after talking to Rafiq Bhai last week, I just collected the EKG from this week. I don't know whether you can see the.
can you show the poll result, Vibhu?
They haven't given,
Sir, 1 minute, sir. 1 minute.
we haven't been able to start the poll.
Okay.
Most of them going with the C or some of them going with D.
Okay.
Yeah. 15 seconds only.
In seconds. Okay, sir.
Second.
Because I'm expecting this will be 100%.
Yeah. Show the result.
Okay,
Okay, not bad.
says it's C.
So
30% D.
okay. Okay. Any comment from the faculty? Otherwise, I go to the next. I think this is very simple.
No, I mean, why do you think it's not D? I mean,
Yeah.
why is it? Yeah, I mean,
Yeah.
B choice sinus rhythm with non-specific ST change is partially true.
Yes.
But the question is, why is D not right?
Because of the anyone, Wadud, you want to explain?
The thing is, whenever you see a negative complex in lead 1, look at the P wave. If it's negative, go to the beside lead, that's AVR. The P wave is upright, the QS is upright. Then it's a dextrocardia, either true or a technical dextrocardia. Then go to the right ventricular lead, V1, V2. If it is a true dextrocardia, then there should be tall R in there, and in V5, V6, there should be very small R. But it's not true. Here from V1 to V6, gradually the R wave height are increasing. So this is the case of technical dextrocardia. That means limb lead reversal.
Very well said, and this is a very common EKG in the exam.
I'm going to summarize it, just quick summary.
Okay.
If you look at limb leads, looks like dextrocardia, but the chest lead looks perfectly normal. That can't be dextrocardia.
Yeah.
Okay,
Thank
so
you.
this one, following the bundle branch concept, 70-year-old with a renal and liver transplant about a year and a half ago, came in with chest pain, had a cath, multivessel disease, cabbage, and this is the EKG day 4. And the answers are in the bottom.
You can't see your answer. You have to read out it because we can see the A and B only.
Oh, okay,
A is fibrillation with RBB, B is atrial fibrillation with RBB, and
anterior wall MI.
anterior wall MI.
C is AFib, right bundle, and post-op pericarditis. And the D is AFib, rep bundle, and want more information such as old EKG.
Can you show the poll box? Poll box.
And these are the real practical issues. There is no right and wrong answer. My first EKG, there is no exception to the rule. Only one answer in the first EKG. Now on, all the EKGs will be clinical oriented. So there is no right and wrong, but you will see that.
So 46% says it is D, that is they want another ECG, and 30% says it B, atrial fibrillation with RBB with anterior MI, and 14% says it's C, and 11% says it A, atrial fibrillation with RBB.
Sir, you were successful. You are instilling good practice into our habit. But we should need, if it is preferable that if we can get an older ECG, because that will help us to differentiate it from whether the patient has pericarditis, post-pericarditis or not.
So I don't know what the panelist will say, but I think AFib right bundle and jump on anterior wall MI, you need to be careful because it doesn't look like that way. AFib right bundle and post-op pericarditis, it doesn't look like pericarditis. So
No,
either you are, yeah.
Yeah. I mean, look at ST elevation in lead V2, V3, V4, and a patient who got a cabbage in right bundle, I can call that anterior wall myocardial infarction acute. Why not?
Yes, I'm coming to that, Rafiq Bhai, because I think this is a practical problem, right? So
Yes.
what I'm saying that when you see this, you EKG and also old EKG and the patient is asymptomatic, and then you don't jump on the anterior wall. Nothing wrong to ask for help, but if you can do bedside echo, wall motion abnormality, this is in the differential. What I'm trying to do is giving you the practical thing that how you tackle this. But the answer is probably better to say right bundle and one more info, like an old EKG. This patient is post-cabbage, old EKG is in the chart. So before you pull your hair, look at the old EKG and then see. So that is probably more, but post-op pericarditis is wrong. B is important to consider, but I think the D is the right answer. What about this one? This is like even simpler. 59-year-old with the delayed presentation of myocardial infarction. LAD was worked on, LAD open. I don't know whether you can see the bottom one. Post-LAD intervention, chest pain better, no reflow, post-adenosine flow improved somewhat. Okay. So what you will do now? This is the EKG.
What are the choices? Question. Oh, good.
Now, you need to see this EKG. This happened 2 hours later. So now your choices are sinus rhythm, new right bundle, B, a new lateral wall MI, lead 1 AVL, and then C, acute vessel closure, and D, hyperkalemia with acidosis. Correct electrolytes, acidosis, and repeat EKG.
One important thing whenever we consider an ST elevation, if there is any reciprocal change. A reciprocal change in the corresponding opposite leads will suggest that it's an acute MI. We should remember always that.
So where is the poll?
Poll show us the result. They have shown the poll. It's
Number C.
67% says it is acute vessel closure, and 21% says a new lateral wall MI, treat diagonal disease medically.
And you have heard Dr. Wadud Chowdhury saying rightly that when there is a significant changes in the opposite leads, and this EKG, this is acute vessel closure. Do not be fooled by anything else. And this is very, very important to recognize. This patient was not recognized, and then see what happened. Look at the EKG now.
There is ST depression 3 AVF.
Sometimes we say tombstone. We don't understand sometimes what is tombstone, but this is tombstone.
Same patient.
Same patient.
This is classic.
Right. So the acute vessel closure following intervention is a very important thing to recognize. And if you have any doubt, don't be too confident. If you cannot make out decisions, please ask for help. Ask and make sure that you involve the operator who did the procedure.
Axis bhai, can you go back with the second ECG? Because everybody should have a very visual imprint in their mind of the second ECG.
Yep.
And this one. Look at the ST elevation. Look at the reciprocal ST depression in inferior leads. This is so important.
Yep. If there is no reciprocal change, Still it is possible, but when there is reciprocal change, then you are what we call it home run. That means you already scored, you know.
But Hafiz bhai,
Yeah.
according to the clinical course, the number 3 should be the number 2 ECG and number 2 should be the number 3 ECG.
Yes, but life is not like that. They after the first EKG, the patient got better. LAD got intervention done, and no reflow, and there was and then somewhat better in the flow. So they were happy. 2 hours later, patient had this EKG.
Hafiz, can you show me that?
Yeah. So this is actually interesting patient because this is the first one.
Can you show me the next ECG, please?
This one?
Tombstone. No.
No.
Which one?
And that one after that.
After.
One after that, we don't have any other.
this
After
one,
that,
this
this is
Okay, can you go back, please?
This one.
Second ECG.
Second ECG.
And I don't know, you can look at the time and date.
Okay.
I have given the time and date on the.
Yeah, it's a little bit time is wrong because the one before was the first.
Yes.
So this is the later ECG.
This is the later EKG, 2 hours after.
2 hours after. No. Can you go to the next one?
Okay, so
Next one is at 3 o'clock in the morning. This
Okay,
is
so-
7:40. Yeah, this is this is the
Okay.
first one that you showed me on
Yes.
the 20. This is on the
Yeah.
4th.
exactly at 12. This is the EKG the patient presented with
Yeah. And the next
in
one.
emergency room. Then
Next
went to the
one.
cath lab, intervention done. So
Yes.
it is about 2 o'clock, 3 o'clock in the morning. And then this is the EKG 5th of October.
Okay, now go to the next one, please.
And this is the EKG. This is the EKG on the
No, this is the ECG at 3:20 in the morning.
Yes, sir.
yes, but okay, I got it.
Yes,
But
yes.
but the thing is,
Okay. Okay.
you are
No, the reason I'm saying this, and this is 7:42 in the morning.
Yes.
So that means 4 hours have passed.
right.
Okay. So this is one important thing that I have to mention to our doctors there. Young doctors, please remember, this is the new time. When I trained, our professors, or we will give prescription to the patient, they will go home. If they did not come back, they are either dead or healthy, one or the other. But this is acute care medicine. And that means when you see an ECG like this, you have to act quickly. And we have all the facilities now in Bangladesh. At one time, we did not have anything. So please make sure that when you see these kind of changes, act quickly and appropriately as soon as possible. And the other part is, if you are a junior doctor, you are afraid to call the senior doctor. But please remember that if you do not call the senior doctor, you will have a dead person. And that person can be, if it is a very rich person, he will scream and shout at you. If it is a poor person, he may not shout at you, the family may not shout at you, but a family will be left without a father or a mother. Thank you.
Okay, Zoik bhai, well said. Because with that note, I want to tell you the next patient. Look at the timing, 3rd of October. Okay, 65-year-old. 65-year-old brought to EMS. Lethargic, neighbors called the EMS. And your choices are, because we have the, okay, so this,
Start a new poll.
Rovik bhai, any comment?
Let's see the new poll.
Wadud, you liking these EKGs?
Yeah. Ugly looking.
Listen, this ECG, what I call ugly looking ECG,
Yes.
it's almost sinusoidal. And there are few things.
Rovik
There are
bhai,
few things you have
Rovik
to
bhai,
consider.
poll লেখানো হয় নাই।
One, agonal rhythm, hyperkalemia, and of course, it can be a slow beating.
So 74% says it's hyperkalemia.
So my question to the faculty, which one you will accept as right?
Hyperkalemia is the cause, but rhythm is the slow beating.
So I deliberately did this, but I think I would not accept STEMI activation for sure. I don't know what Wadud says.
Yeah.
That is absolutely, I would penalize 10 points if somebody call it STEMI activation, really, because if somebody's life is at stake. And unfortunately, this was recognized late, and patients' potassium was really high. But they started treating all that. Turns out to be creatinine high, acidosis, all that. Okay, and please make sure that you know in your brainstem that what you are going to treat with this patient with. Calcium, bicarb, insulin dextrose, oral potassium, resin exchangers, and then if you treat with all these above, also make sure that you call the renal. You can, I'll tell the fellows, you can go home after this. Acidosis is not corrected temporarily, dialysis is not arranged, and then patient will have a rebound hyperkalemia late in the evening and go into a PE arrest. So it's very important. This one, 80-year-old female brought to the ER, this is October 5, with chest pain for 2 hours. আতার ভাই বলেন কখন থামবো? রফিক ভাই, which one you take?
No, I cannot answer this. Let the
No. Which one you will accept as? Which one you will accept as correct answer?
LBB flutter with LBB. LV. C.
So in the board exam,
Look at
the examiners love when they see that the participants are divided. They love it. That means it is a very discriminatory question. So they will keep this question. If it is so, I would say that I would accept sinus rhythm with left bundle, because you really cannot say left bundled with LVH when the presence of left bundle. It is not atrial flutter, because if you look at lead 2, the sinus rhythm is pretty obvious. And then ST elevation MI, there is no Garbosa criteria here. Any comment?
Wadud,
sir.
tell me about the Garbosa criteria so the audience can understand what Hafiz was talking about.
Actually, any LVPV with chest pain, the point is whether the patient has acute anterior MI. Look at any of the leads that have a positive QRS and also ST elevation. We don't have that anywhere. Look at that. Or where there's supposed to be ST depression, negative QRS complex, again, that's it. And negative QRS complex, but also ST depression. That's also not present here. Or the QRS complex and the ST segment is opposite, and the ST segment is too much higher. That's also not present here. None of the Garbosa criteria are present.
Yeah, I totally agree with Professor Chowdhury. So discordant that this ST is going in one direction and the S is going in the another direction, then you need 5 millimeter. But if it is going in the same direction, you need 1 millimeter ST elevation.
Right.
If it is ST depression, it is in the V1 to V3, that is 1 millimeter you need. So these are the 3 criteria in the original Garbosa. And if you have all 3, the specificity goes high. But if you have 1, the sensitivity is there, but you lose specificity. This was used in the Garbosa criteria in the gastro trial for the L left bundle and the STEMI presentation, but now it is taken in the guidelines in conjunction with the clinical presentation, not alone.
Yes.
Some people use the same thing in a paced rhythm. If the patient comes with the chest pain, whether paced rhythm follows the Garbosa criteria or not. Okay, so this is 74-year-old with fatigue, dizziness came to the emergency room at 6 p.m. This is a problem for the interventional guys because they question about what it is. I have not shown you this is a better looking EKG, but this is the chest X-ray of the patient. Further evaluation, blood pressure 100/60, aortic ejection systolic murmur 2/6, no aortic regurgitation. I think this is a practical thing, not for board purposes. That's why I put the choices like this. What you are going to do, because usually you don't find the EP guys in the hospital. Either they are in the lab or they are at home. But we'll have to deal with this. Should we put a temporary wire? And my question to you, complete heart block, do temporary pacemaker now and permanent in the morning. Complete heart block, keep on dopamine or isoproterenol infusion and keep and for the permanent pacemaker in the morning. High grade AV block, temporary pacemaker now and permanent pacemaker in the morning, or give thyroxine and evaluate in 48 hours.
Can I go back to this?
Go back to the EKG, okay.
What was the symptom?
Symptom is fatigue and dizziness. Came
Never
to the
passed, never had syncope.
never had syncope.
Okay.
Jamil, are you here, Jamil?
Yes, sir.
I will find. Yeah.
Sir, we can ask Jamil for his comments, sir.
So what was the answers?
C.
Can you give me the choices again?
C. C means high degree AV blood, ppm now and ppm in the morning.
Okay.
So we actually
Can you,
did.
go back to the, can you go back to the ECG, please?
Yeah. So Rafiq bhai, I just wanted to let you know that what we did, we chose the option C, like put the temporary wire and then permanent pacemaker the following.
Okay. Anybody disagree with that?
Jamil.
Sir.
So this patient
go
came with dizziness, no syncope.
Right.
To me, it seems almost 3:1 every block. And as the patient is symptomatic with just dizziness, if the patient improves symptom with temporary pacing, we can put a permanent pacemaker next day.
So this is my choice. I mean, putting a temporary pacemaker will make everybody happy, especially the CCU nurses. But this patient has 3:1 conduction, never had syncope. And in my hospital, either 5 p.m. I'll put a permanent pacemaker or just leave the patient overnight and tell them that if it has any further problem, call us, we'll put a temporary pacemaker in. In Bangladeshi context, I'll probably just go ahead and put a permanent pacemaker. Now, remember one thing, this one of the problems that people face with permanent pacemaker, that if you put a lead in and can you develop complete heart block, but this patient has right bundle branch block and left anterofascicular block. So even if you poke around in the right side, yeah, left hand. So even if you poke around in the right side, but for practical purpose, the choice answer C is a correct answer.
So Rohit, I tell you what happened, because we were worried about this right bundle, left axis, like, and also we don't have any previous EKG. It looks like a very significant conduction system disease. When we took to the cath lab for temporary wire, the fellow was doing this, and I had to jump in because at one point it was all P wave, no QRS.
No, no. but
Okay.
actually,
Yeah.
You know why that happens? When you do temporary pacemaker in this patient, you have to go in without producing any PVC.
Yeah.
Because you can produce a PVC, and that PVC can block the rest of the pathway, that is the retrograde conduction, into the left posterior fascicle, and that causes. So you have to be gentle when you are going in. But I mean, as you said, 320 AV block temporary pacemaker will be the practical choice. I wait. I normally don't put temporary. I don't like temporary pacemaker.
Yeah, but also I have some comment for the thyroxine guys. By the way, it was retrosternal goiter, and then TSH was normal, and this is not an EKG that you mess around with thyroxine.
Yes.
Yes. So the question, the reason Hafiz put this, hypothyroidism will not cause AV block.
Yes.
Hypothyroidism will cause sinus bradycardia.
Bradycardia.
So please remember that if it is hypothyroid, you will not get heart block.
Very well said, Rafiq bhai. That is a myth around the hospital, even in the internal medicine guys, you know. Okay, so maybe we can stop, or we can do a couple of more. Or
I think it's 11:10 in Bangladesh.
I
Yes.
think
Can stop.
excellent decision. Our participants are enjoying, but I think we should stop today. This should be the last ECG, and we can you can show the.
Stop. We want
for next week.
okay,
But
so
excellent ECG.
with the bundle, I wanted to show one EKG.
Okay.
Okay, this last one, because I just showed this. I think Wadud, you saw this. This patient came in with this EKG, and I'm not asking any question, but it was unfortunate. Look at this right bundle and then ST elevation. Rafiq bhai wanted me to show some angio. So the right bundle and then ST elevation in the precordial leads, you can still read STEMI, right? But in this case, look at the lower panel lead 2. There is a PVC coming almost every other beat. This is a disturbing thing. So we did the cath. No wonder LAD closed, but somehow there is a right coronary occluded as well. So I even don't know how we can explain this with that EKG, whether this is a problem from the alternative bundle. I don't know. Any comment, Rafiq bhai?
No, I mean, suddenly if you look at it, looks like bidirectional VT, but it's probably not.
Bidirectional VT, yeah. But it doesn't look like that.
Yeah.
I mean, in reality, there is sinus.
Yeah.
Beat.
There is. It's a PVC bigemini.
Yeah. Okay.
With acute MI. All right. Thank you.
Sir, from today's program, the most I'm really happy that the students have learned to answer that I need more info. I need the old ECG. I want to compare it with the present ECG. That's a very good habit we need to cultivate. And you have
100% Biba, chamatkar.
I showed this EKG, Wadud. This is a must-read article for everybody in the cardiology, that we recognize this differential diagnosis of ST elevation and how to recognize them. This was in any JM. This is a must-read.
A shoulder down.
Yeah. So, yeah.
Shoulder down.
Okay. So this is shoulder down in Brugada, shoulder down in hyperkalemia, shoulder down in acute PE shoulder. This is called the looking of a shoulder down. Okay.
Atahar sir, shall we go for the ECG of the week now?
Yes, please, please.
If you don't mind, can I share the picture if I can bring it out? Only few seconds.
Okay, okay.
This was which I can you see this?
Okay, yes, yes, nice.
Nice.
Nice venogram.
Yeah, this was okay. So this was a picture. I just copied from Fiverr. So the injection is in the left vein. It's going through
LSPC.
the same, yeah, PLSVC.
LSPC.
And then this
Big one.
This is big one here. Again, hang here. Play this one.
So, Maski, when if the patient develops symptom, you can put the pacemaker.
Yeah. So this is a few pictures I could show. I had.
I think tips from Rofik sir how to do that.
Yeah.
Safe.
I spoke with the guys there. They said they have done 2 or 3 and they can do it. That's fine. And he was telling me success rate is around 95%. So these are the few pictures which I've shown. Again, hang. Okay, that's fine. I think these pictures are good enough, I think.
Yeah. Vibhu, can you show us the bit?
Yes, sir. Showing, sir. I'm sharing my screen now.
Or can you stop sharing?
Yeah, I've stopped sharing.
Sir, can you see the screen?
Not yet. Show us.
I have started to share. Okay, sir.
Yeah, okay, we can
CD.
see.
Okay, you can see.
That's fine.
This is a 57 years old female, occasional vertigo, but no loss of consciousness. Our question was, what is the diagnosis and what are the points in favor of diagnosis?
Okay. Shall I go to the answer, sir?
Yeah, why not? Go to the answer, Vibhu.
Sir, I have started to share the answer.
This is the answer we can see, Wadud bhai.
Yes. Can you see, sir?
Answer. Now it's done.
Okay.
As always, the ECG is recorded over a 10-second. Count the QS complexes, multiply it with 6, you will get 60 beats per minute. The sinus rhythm is there because the QS complexes all are preceded by P wave. P wave appears to be normal. PI interval, QS complex, all are normal. But there are gaps in between the complexes where there's supposed to be one complex appears to be missing. The point is the gap twice the usual RR interval or not? Or 2 PP interval? If it is exactly double, it's sinus pause. And if it is more than that, then it's sinus arrest. And why it's a case of sinus arrest? In case of sinus arrest, P wave is not coming from SN node at all. So there should be a junctional escape or whatever it is. But here, after the pause, the wave that is coming is also from sinus. And if we consider PP to P interval, there is one P that has not come out of its home and has not traveled to the atria to the ventricle. So that's an SA exit block. That's the interpretation. Atahar bhai.
Good news is that most of our participants, I think I should say almost all of our participants, those who took part in answering, actually correctly answered. They told the answer was that this is the sinoatrial block, correctly answered, all the participants. And thanks to our participants, as all the participants correctly answered, so I am not showing name of either of the participants.
Sir,
Sir, will
about
stop sharing now?
no, keep it.
Okay.
So,
The opinion about the treatment of this patient, 57-year-old female,
this is
no
the
loss of.
question.
Well, first of all, the intervals, you have to measure a little more carefully. The first two intervals are 1600 milliseconds. But the second, the pause one is not. 1, 2, 3, 4, 5, 6, 7 is about 1500. There's a 100 millisecond difference.
5, 6, 7. Yeah.
It's not accurate, but I still think it is 2-to-1 AC block. Why? Ideally, it should be double. However, what happens when there is a blocked, the next one P can come out, exit faster from the sinus node area. So there will be little variability, but it is not exact multiple. So when you do these measurements, academic measurements, you have to be exact. It is not exactly multiple, but I still think it's 2-to-1 SA block. And the treatment-wise, unless this is a young person, I'm not going to put a pacemaker in this person, just occasional vertigo, because if patient had occasional vertigo, patient should be having occasional vertigo at this point if it was causing symptom. So if when I did this ECG, patient was having vertigo, then I'll say maybe it is related to this. Probably this has nothing to do with patient symptom at all.
Any more investigation, sir?
We should have a halter then. If there is any, the pause is longer or not, pickup time.
Yeah, I mean, you can do a heart 24, 48 hours, 72-hour heart monitor. And again, what I'm going to do, I'm going to correlate this patient's symptom with the heart rate. When the patient is symptomatic, are we having this pause? Also, at that time when there are pause and no symptom, that is also more important. Please don't always look at positive findings. Negative finding is important because if this patient is having no dizziness when this EKG also happening in other times, then this is not the cause. This is something else. And other problem is dizziness is such a vague symptom that it is very, very difficult to pinpoint. It can be from many different causes. Thank you.
Thank you.
Stop sharing. Stop sharing. I think we are late. It is 11:25. May I request Atahar sir to wrap up the session?
Jamil,
sir,
any comments about the last ECG?
Pardon?
Now, do you have any comments about the last ECG? Rufus has told this patient should the last ECG of the week.
ECG, I think apparently what the participants given the diagnosis we cannot deny, but Rofik sir is more accurate in interpreting this.
Sir, thank you very much, sir. Actually, thanks our participants, dear participants, still they are in the session. Good number of the participants still in the sessions, and today's session was excellent, particularly because of wonderful lecture by Dr. Khalequzzaman, and secondly, it was a nice session today by our Khalequzzaman, that is Urun Maski. That is a nice display of a beautiful ECG display. That is the patient that is a sinus node disease, and also Dr. Chowdhury Hafizul Hasan. Actually, this is a nice demonstration, and I think that our student participants nicely enjoyed these ECG shows. And because of this time constraint, actually, there was another session of our regular session by Dr. Rafiq Ahmed sir. So I think this will be the next day, Dr. Rafiq Ahmed sir's lectures. And in the next week, there will be another wonderful session by our Dr. Monorul Islam. He will talk on the sinus node the disease, that is diagnosis of the sinus node disease. And still I can see some of our participants, that is the Professor Mahbubur Rahman. Mahbubur Rahman, do you have any comment, please?
Sir, no thanks. It is almost 11:30, and all are goods. We respect them. Sir, I
grateful.
think you should wrap up. Yes, sir.
We are grateful
Sir.
that you are still with us. Mohsin
Sir.
Hussain. Mohsin Hussain is still with us.
Mohsin is with us.
Urun Maski.
Hi.
Urun Maski, you don't
Yes.
forget to, you don't forget to bring some like more ECGs in there. Whenever you like, you just let Wadud be know. That
Yeah,
is
fine.
And Chowdhury Hafizul
Yes.
Hasan, please, you can continue your session.
Okay, thank you.
So thank you everybody, sir.
Sir.
We can conclude the
Thank
session. Khalequzzaman, finally, grand thanks.
Welcome, sir. Thank you, sir.